I'm Elizabeth Mueller. I am the Division and Fellowship Director of Female Pelvic Medicine and Reconstructive Surgery at Loyola University Chicago Stritch School of Medicine. I've been using the BK ultrasound, specifically like the transvaginal probes and the transrectal probes, for about 7 years now. The trick is to look for the applications of transvaginal ultrasound that are absolutely unique. And that is, I believe, looking at mesh and also looking at the pelvic floor for lesions that previously you would have used for MRI. Urethral diverticulum, vaginal wall cyst, erosion of mesh into the bladder. I'm interested in looking at the components of the pelvic floor, specifically looking at the urethra, looking at the anal canal, looking at the vagina, looking for mesh in those areas, and then being able to localize the mesh and also dimension it. That's where I think the advantage of the 3D cube has been. Well, now with the 3D cube, once I isolate that leading edge, I can come from on top and come down and see it. And that's exactly how I've solved problems. Or I'll have a piece of mesh that looks folded, and I can see that in one view, and then I come at the second view and try to see, is that truly folded or not? Can I come in at a different end and see just the leading edge here and then see a larger edge on one side? So I think if you're a surgeon operating three-dimensionally, which all of us are, having a three-dimensional tool gets you there a little bit sooner. I'd say that in my clinic every day, about 20% of the patients that I'm seeing are coming in with a mesh complication. Now, not all of them I need to do ultrasound on. If I felt that we need to talk about before sending her to physical therapy, I need to release this mesh, and that's often the case, then I'll go get the ultrasound. I'll try to correlate the symptoms that she's having with what I see on ultrasound. I'll try to use those ultrasound results to go to the operating room with. Sometimes now we have them loaded in our PAC system, so I can open that up in the operating room, and if I have a question, do I have all the mesh, we can take a look again to see what was the distance from side to side, or what was the thickness of the mesh. It's just a refresher before I go in. It's almost like examining the patient again. So when I say to a woman that she's worried about the mesh, or she's worried about that there's something in there, and I have a legitimate reason why I want to do the ultrasound, women aren't troubled by that. And then the other thing is that it's live. I don't know, for many patients, it's a way to dialogue with them. When I'm doing when I'm looking inside someone's bladder, I'm not just teaching the residents with me, I'm teaching the patient. This is what your bladder looks like. This is normal. I'm often using language that's very reassuring. This normally looks like the inside of the mouth, the bladder does, and see how this is what this looks like. That's not irregular. That's what a bladder looks like. When I'm doing ultrasound on a woman and she's convinced that she's got a mesh problem, she's got mesh inside her, and she's got some twing that she hasn't had before, and I say, well, let's do an ultrasound. I feel like it's indicated for a reason. I do an ultrasound. I say, look at that. See, I can see that mesh. It's in a perfect spot. And look, I can see how wonderfully symmetric it is. The person who put that in took their time and put it in carefully. I'm looking here in the bladder. You have a normal bladder wall thickness. I see nothing in the bladder. I'm looking at the muscles. You got very nice muscle tone. Those things are very reassuring, and they're almost therapeutic in themselves. So I think if you have a good indication for a test, and you explain that to the patient, and then you're doing it live and explaining to them what you're seeing live, it's very powerful, and I don't see a downside to that.